Good afternoon, everybody. As it's 12 o'clock, and we respect everybody who has that's on time, we'll start for our first ever SPX talk in English. So it's kind of a historic moment for our organization, Shared Patient Experience. I'm Tom Colin. I'll be your moderator for today. As it's the first time we do it in English, let me briefly introduce you to the mission of our organization, Shared Patient Experience. We're a non-profit, mainly volunteer-based organization, and we want to spread and raise awareness on the importance of patient experience in the hope that we can change the culture of healthcare organizations. We do this mainly through teaching and sharing experiences between healthcare organizations. The most spectacular thing we organized is our colloquium with almost 300 participants last year. It will be organized again in October this year in Barcelona. It will be fully in English and French. We have also the SPX Awards, a few position papers a year. We organize trainings, have a knowledge sharing platform. More info on our website. And of course, there's also the SPX TALKS. That's a series of engaging webinars where we also want to raise awareness on topics related to patient experience. It's just there to give insightful perspectives without delving too deeply into a specific subject. The format is quite simple. It takes 20 minutes that we have a guest speaker that we give the floor to. And then we have a 5 to 10 minute Q&A session where you can participate. Just raise your hand or drop a question in the chat, and we'll hand over at the end of the session. We give you the floor. Mind that the webinar is recorded. It will be made available also as from tomorrow on our YouTube channel. That's for the introduction. Let me now introduce our first speaker to you. So we are glad to have Stefan Gijssels, who is joining us for our first SPX talk this year. Stefan is a metastatic colorectal cancer survivor. He's also a health policy advisor with a beautiful mission to make health systems more patient-centered and smarter. He chaired the Patient Expert Center in Belgium, an organization that trains members of patients' organizations to become patient experts in their disease area. But Stefan will give more info on that when he's got the floor. He's also co-chair of the Scientific Committee of Sharing Progress in Cancer Care. Stefan, up to you. I give you the floor to inspire us on our topic for today. How to incorporate the voice of the patient can help to optimize our care. Over to you, Stefan.
Thank you, Tom, and thank you everyone for inviting me. It will be a pleasure to explain what we're doing. Let me share my screen. And this is not my presentation. This is my presentation. No, this is not my presentation. This is my presentation. 1 second. So, as Tom mentioned, I'm chair of the Patient Expert Center. We're an organization that was created by patient organizations in Belgium in a wide array of diseases: rheumatology, multiple sclerosis, Crohn's and colitis, diabetes, different types of cancer, rare diseases, stroke, migraine. And we're working with the Belgian Cardiological League to start organization for patients with cardiovascular diseases. What do? We do 3 things. Basically, first is training patients to become patient experts. It's a 6-month program, and I'll give some more details in a minute. And once they get their certificates at the end of the training, they can participate in collaboration projects with government agencies, hospitals, and industry, but also counsel individual patients and their families. Many of our professional audiences often ask us, yes, we want to be patient-centric, we want to listen to the voice of the patient, but how does that work? And so we've set up a second activity, which is the design of collaboration models between patient organizations and our professional partners, so that we can design services with high added value that in the end will generate better outcomes for patients, better quality of life, but also better value for the partners that we work with, of course, including the hospitals. The training program that we organize consists of 2 parts. One is a generic or general training where all the diseases are together. And we talk about the healthcare system, how it is organized, how it is set up, what are the rights of patients, what is GDPR, what is ethics, and then how to work with professional partners and how to counsel individual patients. So all the social aspects, psychological aspects are integrated in that as well. Second part of the year, they get a training on their specific disease. They're split up in different groups. And they get to learn about the causes of the disease, the current treatment options, what's in the pipeline, and then also living with the disease, studying or working, specialized care, and then the practical organization of managing your disease and treatment. And then they also learn about the positions of the patient organization they belong to, surveys, etc., to be able to talk with more knowledge about their positions. So far, we have already trained 150 patients who received their certificate as patient experts, and we have 150 more in training this year, so it's moving forward quite nicely. And we've already set up more than 200 collaboration projects with patient organizations, government agencies, hospitals, and pharmaceutical companies primarily, but also med tech companies. So why do we do all this? First of all, I think there's a clear need of patients, and I will not go into the stories, that you can read them, I think, afterwards, but many patients are confronted with issues as a consequence of incomplete information they receive at a hospital, and they're confronted with these problems afterwards. So we want to make sure that we capture these stories, that we capture the incidents that are happening during the treatment, and that we afterwards also try to work with the hospitals to increase the quality of care. We have no idea how many patients are subject to this situation, but a recent study in Wallonia in Belgium showed that around 1 in 6 patients is confronted with potential incidents in hospitals. A second observation is that we live in the prehistory and space age at the same time. So many things are absolutely fantastic and spectacular. We love all these high-tech things on the right, the robotic surgery, genetic tests, CAR T cell therapy, AI, implants, cell and gene therapy, all fantastic. And as patients, we applaud what is happening. But then on the basic side, we see that many things are neglected because they're cheap, they're not spectacular, they're down to earth. We see that GPs don't ask questions about the family history of the disease. Very few people get nutrition advice. I mean, we still have patients who get no information that chemotherapy impacts fertility, for instance. There are limited outcomes measures on quality of life, limited assessment of information need of patients, and lack of personal support for those who are not capable to do it themselves, with limited health literacy or with a different cultural background. So many basic things that can make healthcare more effective and efficient are currently ignored because they're outside of the perspective of the healthcare system. And there are 2 types of knowledge. I mean, multidisciplinary teams know a lot, but patient organizations know also a lot. And it's a different type of knowledge, but I think both are complementary. And I'll give some examples about recent quotes that I received from physicians. On the left, it's a radiotherapist oncologist who gave a testimonial in the medical journey here in Belgium. Her husband unfortunately died of pancreatic cancer, and she says, "It changed my outlook on the disease. I've learned an enormous amount. Aspects of care that are essential for the individual cancer patient I had never realized before as a doctor." The second quote comes from an oncologist from Sweden when I was participating in a European Cancer Forum a couple of years ago. We had a discussion among patient survivors of cancer. And the moderator asked this oncologist who was sitting on the first row what his reaction was. And he said, "I've been an oncologist for 20 years, but this is the first time that I hear about the problems cancer survivors are confronted with in daily life." And this sounds maybe bizarre if you're a doctor in your day-to-day job, but it's a different perspective, it's a different reality. And this is something that we have to work with. I often share this slide. On the left, you have the engineer who designed the induction cooktop and published in the engineering journal Sensors in 2014. And on the right, you have the couple cooking. And that's a little bit of reality. I mean, it's fantastic to know all this engineering thing, and you cannot design it properly if you don't know how people are going to use it afterwards. But I think the people on the right know more about cooking than the engineer who designed it, probably. He knows more about the engineering part, the couple knows more about the food, and I think it's a little bit the same in our healthcare system. So, how do we work? Maybe let's share this as our 360-degree vision. If you organize healthcare, you have to take into account the medical perspective and the patient perspective, both at individual and collective level. A lot of the attention that we have in our system is focused on the quadrant on the top left: diagnosis, treatment, supportive care, and follow-up. We know that if you want this to be absolutely successful, it has to match the expectations and the context of the individual patients, the life goals, the life expectations, family context, social context, financial context, professional context, the level of health literacy of the patient, experience with the disease, practical organization at home, the bureaucracy or dealing with the bureaucracy and the paperwork to get reimbursement, to be aware of what is reimbursed and what you're entitled to. And then, of course, navigating the healthcare system, which services are available, how to find them, how to have access to home care, where to go for an electric wheelchair, etc., etc. So the more, if you really want optimal care, the more this care at the top left is adapted and matching the expectations of the patient, the better care will be, the better adherence to the treatment will be, and the better the outcomes will be, and also faster. I think there are numerous studies that have already illustrated this. What we as patient organizations do is on the bottom right, we give support to these individual patients who need it, to make sure that the quality of their understanding of their treatment is actually organized in the best possible way. By doing that, we have the collective intelligence and sometimes data on the entire community of patients affected with the disease. We can identify needs, we can identify problems, and we can come with practical and creative solutions like toilet pass, as we have it in Belgium, or the right to be forgotten, and other systems. And then we can advocate, and we go to the health policy part on the bottom left to make sure that it's integrated in overall health policy, so that it also improves the medical practice on the top left. So that's the view we have and that we try to work around. So what we want to avoid, we know that once a patient leaves the hospital, is discharged, there is the complexity of the human context, the family situation, the lack of individual support, the actual lack of understanding, etc., etc. And so you have a kind of cascade effect downward, a kind of waterfall effect, where the ideal conservation of the treatment actually diminishes as we move forward. And we want to make sure as patients, organizations, that we have the light blue part, that we help patients to keep the optimal treatment they received in the hospital. Secondly, we want to make sure that we even increase it by having processes of shared decision-making integrated into the decision-making process in the hospital, by having patient-validated processes, and by having surveys and feedback mechanisms to make sure that the voice of the patient is actually fully integrated in the decision and the treatment plans in the hospital. So we can help to improve care. So at one time we avoid loss of value, or we help to increase value. And I think that's, in the end, the value of patient organizations for hospitals. And what we try to do also is to make sure that entire patient pathways are taken into account. We will look at from prevention or early detection to end of treatment, all the different steps, identify the best practices and how things can be improved. This is a model that we took from Tuscany in Italy, where all the public hospitals share their data. For instance, in screening, the best practice in the Netherlands, 71% of colorectal cancer, of patients participate in colorectal cancer screening, compared to 13% on average in Europe. So there's a lot of upside possible. So in the Netherlands, 48% of colorectal cancers are diagnosed in stage 1, compared to 23% in Belgium, for instance. And these are thousands of lives, where 90% survival in stage 1 compared to 8% in stage 4. So there's a lot of upside by organizing care differently. In Belgium also, the difference in overall survival for colorectal cancer is 85% in the best hospitals compared to 50% in some other hospitals. So 35 percentage point is a lot for people having access to the same level of care, same system, same reimbursement. And so we as patient organizations can also help to collect the data, to ask for better treatment, to advocate for better care, and to identify the best practices and make sure that they are actually exported to other hospitals or places or geographies. The patient expert himself assists individual patients. So once they're diagnosed, they can talk to our patient experts at the patient organization. They will first of all listen to the patient, see whether they understood all the different problems, the treatment, etc. We can prepare questions, we can discuss taboo topics, we can make sure that the patient is also navigated to the right expertise outside the hospital if the need is there, or we can help with the consultations if that is needed. We also work with industry. We have a work stream where we designed 8 priority areas. I will not list them, but they're here. You can look at them, starting from clinical research to company culture. And that we designed since the beginning of last year. Same thing with government agencies. We participate in roundtables, in advisory boards, regulatory pathways, etc., etc. So it's good to be part of the process, to co-design if possible, to participate in consultations, and sometimes to lobby for improvements that we have identified. And then with hospitals, we have also a working group, and we identified 6 priority areas to work in. So we asked the hospitals which services will add the highest added value to your day-to-day work based on the insights of patient organizations. And so we selected these 6 clinical research, development of care pathways in the hospital, education and health literacy of the patients, quality of care, and then staff training and patient-centric culture in the hospital, especially to make healthcare professionals in the hospital understand the complexity of the problems that patients are confronted with outside of the hospital. And then governments can be participation in ethic committees, project teams, and other teams in the organization. So the way we do it, we work together with a number of hospitals. We look at what's available in the literature, and in clinical research already a lot exists, and there are international programs at European level, Paradigm, Prefer, Patient-Focused Medicines Development, New PATI, where patient engagement is described in very robust way on how this can be integrated into clinical research, both for companies and in hospitals and university settings. And it shows in every step how the patients can be part of the process. To do that, we have process descriptions, we have background documents and additional information. This will all be available on our website. It's called patientexpertcenter.be, and we have a toolkit there where you can look at the documents. We're trying to make them a little bit more fancy and less bureaucratic, so that people can work with more pleasure in it. These are flow charts, but it helps to make the system more systematic and robust. So it's not just a check the box, we listened for an hour to a patient, now we know what's going on. No, it really wants to make sure that we have a process that is systematic, well-structured, validated by the different parties, and sufficiently robust to be used. The templates that come out of this, of course, are not disease-specific. They are general templates, but then they need to be adapted in project work based on the disease, and the severity of the disease and the requirements. We also look at different ways of capturing patient journeys. So we work with metro mapping, which helps design the multi-stakeholder perspective on the entire patient journey. We're also looking at more dynamic ways to make it digital, available rather than a written document, but we want to be effective, useful, and applicable in the hospital, as well as being useful for the patient by integrating the voice of and the situation patients are confronted with. Same thing with care pathways. mapping systems, and then follow-up tracking afterwards. I will not go into the detail of that because I think this will take a little bit more time, but it's always the same system. We describe the process, we have the flow charts, we have the step-by-step plan, we have the task division between the different partners, and then we have background documents, sometimes digital tools, to actually work with it and make it actionable for both parties. We have a number of hospitals. We're active in Belgium, but I think the model is also applicable to other countries. We have our working group, and then on the right you have hospitals that we are currently in conversation with to take things a step further. I think the ingredients to our cooking is that we start, of course, with the treatment protocols in the hospital. That's the backbone. It's the medical scientific approach. Every hospital has their own culture, has their own approach. We, of course, integrate that as well. We try to listen to patients who have been treated in the hospital to make sure that we capture their ideas, their experiences, their satisfaction. We identify the needs. We have a full inventory with treatment information support outside the hospital. We try to make a creative approach. Okay, if you as patients would be in charge of the hospital, what would you change based on the experience that you've had, so that we can integrate new ideas that patients may come up with. And then, of course, integrating patient-relevant processes like shared decision-making models, referral to experienced patients to discuss things before actual decisions are being made. And then, of course, strong agreements between the hospitals and patient organizations, task division, visits in the hospital, information sessions on specific topics, and things like that. So there's a lot that can be done. We just want to make sure it's done in a consistent and professional way, and in a pre-competitive way between the hospitals. So it's pointless to reinvent the wheel time and time again. I think if we have collaborative models that we can implement everywhere, I think everybody will gain time, and it will be validated by everybody, so that helps. So in sum, it will be better for patients, definitely. It will also be better for the hospitals, and also give better satisfaction, I think, to the people in the hospital, that they work with patient integrated systems. And of course, for the authorities and industry, it will also have benefits, but in different areas. So this is basically what I wanted to tell you. I want to thank you for your interest, and I'm sure if you want to have follow-up discussions, feel free to contact us, even if you're not based in Belgium. I mean, we're open to discuss things outside of Belgium as well. And I'm available for questions.
Thank you very much, Stefan, for your inspiring story. And also congratulations with the spectacular results. 300 certified patient experts, over 200 collaboration projects. That are some impressive results. I look to the audience. If the questions you have for Stefan, raise your hand or just drop it in the chat. I'll start with a question for you, Stefan, and waiting for other people giving a question. Is there any advice you would give to healthcare providers or organizations that are just beginning to explore ways to integrate patient voices into their services? Got any tips or a small practical advice we can take home?
Yeah, I think it's. I mean, you have many different types of patients, and I think it's very important that you work with patients who get the training. I think it's many patients if they're not. We train patients to tell the story of all the patients in the community. Mm-hmm. So I know some organizations start with a patient advisory report, and it doesn't work out because people talk only about their own problems and their own personal situation, and it's not relevant for the entire hospital or the entire group of patients. So you really have to make sure, first of all, that you have the right patients in your patient advisory board or patient pools or focus group sessions to really capture what you need as an organization. I think this is a very critical point. Yeah. And I think you can, sorry.
Oh, thank you for that insight. I see that there is a hand raised by Joep.
Hi, Stefan, thank you for an excellent talk. What, in your experience, has been the major source of resistance within hospitals to your approach? When you approach them and they're not excited, why is that?
Well, I think the positive note is that we find a lot of traction at the moment. It's a new thing, so we're also a little bit exploring. So I think this is on the positive side. I think many hospitals are not organized to welcome the voice of the patient in the way we present it. So it takes a little bit of time to make sure that it's integrated. And even most of our contacts are with the quality teams in the hospital. So they really, they're responsible for the processes and the way it's captured in a systematic way. But it doesn't mean that in every department in the hospital, people are willing to use it. Yeah. So even within the hospitals, you have resistances to changing certain practices. But I think, and I'm positive about that. I think the more we work, the more it gets traction, the more we can demonstrate results. I think the broader it will mainstream in the hospital. The critical thing for us is that we have to deserve the collaborations. I think this is a result of merit. We don't try to impose anything. It's a coalition of the willing, and the companies and the hospitals that work with us, they want to do it. So we work in the way of least resistance, if you want. We're not imposing anything on anyone.
Thank you, Stefan. I've looked at the time, and I think we'll respect the time for 30 minutes. So I'll propose to end our session. I thank you for joining us today, and Stefan, specifically, our gratitude to you to give this inspiring talk and for sharing your expertise with us. I also want to announce our next webinar. So on April 17th and the May 22nd at noon again, 30 minutes, the same format. Don't miss out and check our website for more specific information. You can also subscribe to our newsletter of shared patient experience, so you stay up to date about all developments and events within our beautiful world of SPX. If you have missed part of the session or you want to inspire a colleague, the relationship, know that the session will be made available via our YouTube channel as from tomorrow. So thanks again for your participation. I hope to see you in the next event of SPX, and have a nice afternoon. Goodbye.
Thank you. Goodbye.